All right. Good day, everyone, and welcome back to Neuro Clarity Podcast, where complex neurology becomes crystal clear. My name is Onowori Victor, and I am a neurology applicant. We are currently in Chapter 2 of the Ching Cheng's Comprehensive Review of Clinical Neurology, and we have done questions 1 to 21. Today, we'll be doing 22 and 23, and that being said, let's dive into our case. We have question 22. What syndrome can you expect in a patient presenting with acute stroke and with the MRA shown in figure 2.5? So here's our MRA. So A, Wellenberg syndrome, B, Parinaud syndrome, C, left MCA syndrome, D, locked-in syndrome, and E, Dejerine-Rouse's syndrome. Let's start with our case. Let us take a look at this MRA. We are told that this MRA was obtained for a patient with sudden, severe neurological decline. Looking at this MRA, what is the most prominent finding? Can you see it? Something is definitely missing. Let's compare this with a normal MRA. This is normal. This is the textbook definition of normal. And this is what we have. What's missing? You got it right. The basilar artery is absent, and this is likely from an acute obstruction. Basilar occlusion is a catastrophic event. It can cause pontine infarction, leading to the terrifying locked-in syndrome. And if it's extensive enough, it can result in brainstem infarction, which can result in brain death. Basilar occlusion can happen through different mechanisms. One, you could have local thrombosis of the basilar artery itself. Secondly, you could have thrombosis of both vertebral arteries. Thirdly, you could have thrombosis of a dominant vertebral artery when the other is underdeveloped, and sometimes it's not even a clot formation, and embolus can just travel all the way up, lodge distally in the basilar artery, and cause an occlusion. Other brainstem syndromes are important, but they are quite different, and from the option, let's try to eliminate them. Wellenberg syndrome is from a lateral medullary infarct and usually involves the pica or the vertebral artery, not the basilar artery. Parinaud syndrome, what's that? That's a dorsal midbrain dysfunction, often from a pineal tumor or a midbrain stroke, and not a basilar occlusion. Dejerine-Rouse's syndrome, this is a fancy name for thalamic pain syndrome, and it comes from thalamic infarct and not the brainstem. Remember, thalamic circulation comes from which of the arteries? Did you say the posterior cerebral artery? If you said that, then you are correct. It comes from branches of the posterior cerebral artery. In basilar occlusion, the key features to remember are 1. Quadriplegia from corticospinal tract injury. 2. Anarthria, which is loss of speech ability while consciousness is preserved. 3. Preserved eye movement, especially vertical gaze, because the midbrain is spared. 4. The patient is locked in, which is tragic. They are fully aware, but they are unable to move or speak. Take home points. If a patient suddenly loses all motor functions but can blink, think basilar occlusion. This is a clinical emergency, and remember, time is brainstem. That being said, from our option, we've said our answer is options D, the dreaded locked-in syndrome. Question 23. An MRI is shown in figure 2.6. Which of the following is correct regarding this condition? Let us take a look at this MRI. Options A, aphasia and neglect are common neurological manifestations. Options B, transesophageal echocardiogram with bubble study and Holter monitor are indicated. Option C, pathological analysis of this lesion would demonstrate microhemorrhages in the affected area. Options D, it is caused by occlusion of a penetrating vessel and intimately related to hypertension. Options E, the most common presentation in this case is pure sensory deficit. Now, let's take a look at our MRI again. What do we think? So first, this is a DWI, and we are currently looking at an axial MRI of the brain, the patient supine, head facing up. This section is through the basal ganglia. I can see the caudate nucleus. I can see the lateral ventricles. And I can see an area of hyper intensity located somewhere at the left caudate nucleus, at the tail of the caudate nucleus. This hyperintensity is an area of restricted diffusion, and it is classic for a lacunar infarct. Lacunes are caused by occlusion of small penetrating vessels, most often due to lipohyalinosis. Lipohyalinosis is a pathological change that is tightly linked to chronic hypertension. But wait, let's be clear. This isn't about microhemorrhages. This is about small vessel ischemia, not bleeding. Because lacunar strokes are small vessel diseases, extensive cardiac workup often have low yield. Basic investigations like a transthoracic echocardiogram and cardiac monitoring are still part of comprehensive stroke evaluation, especially if a patient has other risk factors. Let us localize. Based on the MRI location, this lacune is not in the thalamus, so a pure sensory stroke is unlikely here. Here's a critical point to remember. Aphasia and neglect are signs of cortical infarct, not lacunar strokes. Subcortical strokes like this one cause either motor or sensory deficits, but no cortical signs. So, back to our question. We've succeeded in eliminating options A, B, C, and E. And we've said tentatively that hypertension is intimately related to strokes of the lenticulostriate arteries. This has been another quick neuroclarity drop. Small strokes, big understanding. Stay sharp, and I will see you next time.